CCS cases rapid fire review. Case number 1. Suppose you have a kid who has generalized edema and history of respiratory tract infection. Examine. For general appearance, swelling of the body, pedal edema, head, eye, ear, nose and throat for edema and swelling of the eyes, chest for signs of pleural effusion, abdomen for signs of peritoneal effusion, extremities for pedal edema, and genitalia for scrotal edema in case of a boy. Diagnose. Preliminary, get a urine analysis done and fast forward to the results to look for proteinuria. Specific, related to nephrotic syndrome, urine 24 hours protein, albumin which is going to be decreased, urine 24 hours protein greater than 3.5 grams per day, lipid profile which will show hyperlipidemia, chest x-ray might show pleural effusion, and C3, C4 which are normal in nephrotic syndrome due to minimal change disease. General, CBC, LFTs, basic metabolic profile. The patient can be treated in the home or office and there is no need to transfer the patient to the inpatient unit. Treatment, prednisolone, dietary protein restriction. Advice, reassure, counsel. Follow-up examination of head, eye, ear, nose and throat, general and urine analysis, and the diagnosis is nephrotic syndrome. Case number 2. Neonate with difficulty with vomiting and difficulty feeding. On examination, do a general physical examination in head, eye, ear, nose and throat and look for epicanthal folds, flat nasal bridge, protruding tongue, low set ears, cardiac murmur and cardiac murmurs in heart findings. Diagnosis can be with abdominal x-ray since the child is having vomiting and difficulty feeding to rule out intestinal obstruction. Fast forward to the results, you will find double bubble sign which shows duodenal atresia. Transfer the patient to inpatient or ICU depending upon if the patient is hemodynamically unstable. Treatment. Number 1, surgery. Consult pediatric surgery. Number 2, supplementary treatment with NG tube, decompression, IV access, and normal saline. Number 3, pre-op specific investigations. Karyotype, TSH, echo, karyotype in order to look for trisomy 21, TSH in order to look for hypothyroidism, as well as increased values of TSH, echo to look for cardiac abnormalities such as AVST, and CBC in order to look for some sort of leukemia, and basic metabolic profile which is a pre-op test. Advise, counsel, reassure. Consult 3 particular areas: genetics for consultation for counseling of Down syndrome, peds cardiology for cardiac malformations, AVST, and peds endocrinology for hypothyroidism. So the diagnosis is duodenal atresia in Down syndrome. Case number 3. A 2-day-old boy with villous vomiting. In examination, do general examination in order to look for signs of jaundice and yellowing of the sclera. Abdominal examination to look for hepatosplenomegaly or abdominal distension. Chest, heart and rectal examination in order to look for stool. Diagnosis is with abdominal x-ray. Fast forward to the result to rule out perforation. Then get an abdominal ultrasound done and fast forward to the results and find out that it is malrotation. Transfer to the patient to inpatient unit or ICU. So whenever you need to do surgery for the patient, transfer him to inpatient or ICU. So in treatment, supplementary treatment with NG decompression, IV access and normal saline. Specific labs pre-op can be CBC, BMP, PT, APTT in case of an adult, specifically PT, APTT, echo, ECG and cross-match, and LFTs. And for surgery, consult pediatric surgery. In advice, counsel, reassure. And the diagnosis is malrotation with volvulus, and the differential diagnosis can be intussusception, intestinal atresia, meconium ileus, necrotizing enterocolitis, and duodenal web. Case number 4. A 5-year-old male who has 5 days of jaundice after use of trimethoprim sulfamethoxazole for respiratory tract infection. So this specifically tells us that the jaundice developed after the use of this drug. So in the examination, look for general yellowish discoloration of the skin, and then head, eye, ear, nose and throat. Similarly, look for yellowing of the sclera, chest and heart in order to look for any signs and symptoms of anemia, tachycardia or benign flow murmur, and abdomen for hepatosplenomegaly, and you can also do a complete physical examination. In the diagnosis, specifically look for signs of hemolysis, which can be found by CBC, which can show decreased hemoglobin, retics, which will be increased in hemoglobin in hemolytic anemia, LDH increased, and bilirubin, which will also be increased, specifically indirect hemoglobin. Fast forward to the results. Treatment specific: stop the particular medication, get haptoglobin test done in order to again look for hemolytic anemia, Heinz stain to look specifically for G6PD deficiency, and G6PD activity quantitative, as well as Coombs test for hemolytic anemia. In general test, CBC, BMP, LFT, and advise patient to rest at home and reschedule in 1 day. After that, advise him, counsel, reassure, and consult him onc as well as genetics because of the diagnosis of G6PD deficiency. Case number 5. A 6-year-old who has jaundice as well as the mom is not able to breastfeed him properly, and the mother has decreased breast milk. On examination, do a complete physical examination in order to diagnose him: CBC, LFT, bilirubin, basic metabolic profile, and antiglobulin test. Fast forward to the results, which will show increased bilirubin. Treatment: transfer to the inpatient unit because this child has indirect hyperbilirubinemia that can actually damage his brain. Therefore, he needs to be transferred to the inpatient unit for phototherapy. Advise mom to continue breastfeeding as well as supplement with infant formula so that the enterohepatic circulation and the increased bilirubin levels that are circulating because of the decreased presence of breast milk and decreased conjugation of the bilirubin, they can be removed by administering infant formula. And advise, counsel, reassure the patient, and once the patient less jaundiced, you can discharge the patient from the inpatient unit. And the diagnosis is breastfeeding, neonatal jaundice. The differential diagnoses include hemolytic disease of the newborn due to ABO or RH incompatibility, hereditary spherocytosis, G6PD deficiency, Gilbert syndrome, or physiological jaundice, or biliary atresia, which will specifically have conjugated hyperbilirubinemia. Case number 6. 14 female who has short stature and has not had her first period up until now. On examination, do a complete physical examination and specifically look for webbed neck, cardiac malformations, and specifically some sort of a murmur. Similarly, look for short stature, and in the diagnosis specifically get the karyotype done in order to look for Turner syndrome X0, and get endocrine diagnosis done and endocrine blood tests done such as LH, FSH, TSH, blood glucose. In radiological tests, get an echo, abdominal ultrasound, audiometry done in order to evaluate for cardiac abnormalities, horseshoe shaped kidney, as well as ear abnormalities, and bone age in order to look for the bone maturation as compared to the girl's age. And in general, get basic metabolic profile, LFT, and CBC done. In treatment, the specific treatment focuses on replacement of estrogen, so give conjugated estrogen and growth hormone. And in general treatment, give her calcium, vitamin D, as well as weight loss advice. Since she has short stature as well as increased weight. Advise diet high in calcium. Advise estrogen medication compliance and side effects of the medication. Advise exercise, and reassure and consult genetics, peds endocrinology specifically for the problem of amenorrhea, and peds cardiology specifically for the cardiac murmur and any coarctation if present, and peds nephrology specifically for horseshoe shaped kidney. And if the murmur is present and there is possible coarctation, then get an ECG, chest x-ray, PA, echo, and surgical consult done. And the diagnosis is Turner's syndrome. A 6-year-old who has ear pain, or a 9-month-old who is irritable, fussy, and has fever. In examination, do a general examination with head, eye, ear, nose, and throat that might show tympanic membrane erythema or bulging. This is a clinical diagnosis of otitis media and does not need to be investigated. The treatment is amoxicillin or acetaminophen for 7 days. Advice regarding medication compliance whenever you are administering antibiotics. Counsel and reassure the patient, and schedule in 1 week, after which you are going to discontinue the antibiotics, and the diagnosis is otitis media. Case number 8. 1-year-old who has sudden high-grade fever and a blanching macular rash, and he can also have nausea, headache, sore throat, runny nose, itching, as well as arthralgias. In the examination, do a complete physical examination and look for this blanching macular rash. Diagnosis specifically there are no specific investigations for this blanching macular rash with high-grade fever because it's possible the child has erythema infectiosum or fifth disease, but you must rule out other infectious causes such as some sort of blood infection with CBC that can show leukocytosis and urine analysis in order to rule out UTI or urine culture sensitivity or chest X-ray if you are suspecting some sort of chest infection. The treatment is simply acetaminophen if all of the above tests are negative. So that means that this child is suffering from erythema infectiosum instead of some other infectious etiology. And in advice, counsel, reassure, follow up in 2 days, and do a skin, head, eye, ear, nose, and throat re-examination. Case number 5, a 6-year-old who has fever and generalized maculopapular rash along with cervical lymphadenopathy. So in the examination, do a complete physical examination in which you will look for the rash and the lymph nodes, and you can do a neuro and psychiatric physical examination as well. So whenever the child has fever, it's important that you get a pulse oximetry done. So first of all, get pulse oximetry done. If the SATs are low, then administer oxygen. Then do the general blood tests of CBC, BMP, LFT, and ESR, especially keeping in mind that the child has rash, fever, and lymph nodes, the triad that is possibly infectious mononucleosis. And specifically get infectious mononucleosis or heterophile antibody testing done and fast forward to the results. Now, if they are positive, then begins the treatment with acetaminophen, advise no aspirin, and avoid contact sports, and advise counseling and reassurance. And the diagnosis is infectious mononucleosis with the differential diagnosis of CMV, HIV, strep throat, Toxoplasma gondii, and viral infections. Case number 10, 5-year-old who has sore throat, drooling, and has not had any vaccinations. So you're going to do a complete physical examination, or since the child has drooling and sore throat, it's an emergency, it might be an emergency situation, so it's best just to do a focus examination with general appearance, head, eye, ear, nose, and throat, chest, heart, and abdomen. And I have already told that whenever you have fever, it's important that you get pulse oximetry done, and if this oxygen saturation is low, administer oxygen. In the diagnosis, get general tests done such as CBC, BMPL, LFTs, and specifically since the child has sore throat and drooling and does not have vaccination, so you are suspecting epiglottitis due to H. influenzae. So this is important that the child gets laryngoscopy as well as intubation and mechanical ventilation done before these specific tests are done, because if the airway is compromised, we cannot go on doing other diagnostic tests. Right? So once you find out that the child has low oxygen saturation, quickly fast forward to do a laryngoscopy as well as the findings of a swollen epiglottis, and intubate and mechanically ventilate and admit to ICU. Then you can do the remaining tests of CBC, basic metabolic profile, LFT, X-ray neck showing epiglottitis, thumb sign, and blood culture sensitivity along with throat culture sensitivity before you start the antibiotics. But securing the airway is before the blood tests as well as the antibiotics. Then you are going to treat him with ceftriaxone along with vancomycin and acetaminophen for the control of fever, and advise, counsel, and reassure the patient, along with catch up on all the all the vaccines that the child has not received, such as vaccinate against Hep B, DTP, HIV, MMR, chickenpox, polio, pneumococcal vaccine, rotavirus, as well as Hep A and influenza, and as well as COVID vaccine. So then discharge the patient and stop the antibiotics once the patient is feeling better. So the diagnosis is epiglottitis with the differential diagnosis of angioedema, croup, firm body diphtheria, laryngitis, caustic ingestion of some sort of an acid, peritonsillar abscess or retropharyngeal abscess. Case number 11, 5-month-old who has high-grade fever, vomiting, lethargic, and is fussy. In examination, do general skin, chest, heart, abdomen, as well as head, eye, ear, nose, throat, and you can also do a neurological examination. So in head, eye, ear, nose, throat, you find a purpuric rash on the legs and the buttock and the skin, and the papilledema on the eye examination, and and fundoscopy basically shows the optic discs to be blurry, and the child can have nuchal rigidity along with bulging of the fontanelle. Again, since it's a case of high-grade fever, immediately get pulse oximetry done, and if administer oxygen, and if he's unstable, immediately shift to the ICU. Otherwise, shift him to the inpatient unit since you are suspecting some meningitis. For the general, do CBC, LFT, BMPs, and specifically get blood culture drawn before you administer the antibiotics. So blood culture, urine analysis and urine culture for urinary infection, chest x-ray, PA for respiratory infection, and lumbar puncture along with CSF studies such as stain, culture sensitivity, protein glucose, cell count, and meningococcal antibodies in order to rule out meningococcal meningitis. And in the treatment, ceftriaxone, vancomycin, along with antipyretics such as acetaminophen. Consult pediatric infectious disease and notify public health department. Start antibiotics after the culture sensitivity and before the results of culture. Don't wait for the culture results to start the antibiotics, and monitor vital signs and temperature. And advise, consult and counsel and reassure. And the diagnosis is meningococcal meningitis. Case number 12, a 3-week-old who has erythematous papular rash along with difficulty sleeping. His diaper has some sort of a strange odor and he's restless, and he had home birth or birth which was present outside the US. So on examination, you will do a complete physical examination with skin, general appearance, genitalia, which will show you a damp, stale, smelly diaper, and the neurological examination can show you an irritable and a difficult to console baby. And in the diagnosis, general tests such as CBC, LFT, BMP, and specifically get serum phenylalanine test done. So even though you know that this patient might be suffering from phenylketonuria, just remember that even though ketones are excreted in the urine, the diagnosis of phenylketonuria is not based on phenylalanine in the urine, rather it's based on phenylalanine in the serum. So always advise serum phenylalanine to be done. Then the treatment is just low protein diet, a formula, and consult the dietitian to keep the protein low in his diet. And then in advice, counsel, reassure, and as well as consult genetics. And the diagnosis is phenylketonuria, which is phenylalanine hydroxylase deficiency with the differential diagnosis of tetrahydrobiopterin deficiency. Case number 13, 6-year-old who has generalized bone and joint pain along with chest pain and dyspnea, and the child is basically African American. So immediately, because of the bone and joint pain, chest pain, you are thinking of some sort of sickle cell disease, acute chest syndrome, or crisis, and might be due to pneumonia. So in examination, do a complete quick physical examination, and before that you can also do pulse oximetry in order to check for the saturations, and if they are decreased, administer oxygen immediately. Then in the diagnosis, do a general CBC peripheral blood smear in order to look for schistocytes, CBC to look for decreased hemoglobin due to hemolysis, and basic metabolic profile, and PT-APTT. In infectious, you have to chase out the cause causing this acute sickle cell crisis, which might be chest x-ray, PA, rule out respiratory infection, blood culture for blood infection, urine analysis, and urine culture for urine infection. And specifically, get blood hemoglobin electrophoresis done, as well as sickle cell qualitative tests done in order to diagnose the child as having sickle cell disease. Then transfer the patient to the inpatient unit and do the general measures or supportive measures of IV access, normal saline and morphine for pain control, as well as adequate hydration, and to dilute the blood or red blood cells that are sickling in the vessels, and specifically get a blood type and cross match and transfusion done. Administer hydroxyurea to increase the concentration of hemoglobin F, and administer folic acid and B12 since these children are at an increased requirement of hematopoiesis, so they will need folic acid supplementation. And specifically, if the child has you have found an infection on the chest x-ray or blood culture, administer ceftriaxone, and for prevention of repeated infection, administer penicillin V monthly. Similarly, advise, counsel, reassure, and medication compliance, consult peds, hem-onc, as well as meningococcal vaccine, since the children with sickle cell disease have functional asplenia and are susceptible to encapsulated organism infections. So the diagnosis is sickle cell disease and acute chest syndrome due to pneumonia with the differential diagnosis of sickle cell trait, sickle cell anemia, respiratory tract infection, pneumonia, as well as acute chest syndrome. Case number 14. Postmenopausal female who has vulvar itch, pain, bleed as well as discharge. In examination, examine the genitalia looking for raised, fleshy, ulcerated, warty, white lesion, lymph nodes for lymphadenopathy, general chest, heart and abdomen. In the diagnosis, specifically get a vulvar biopsy done and pap smear and fast forward to the results. And if it shows malignancy, then we will go by the diagnosis of vulvar carcinoma. Rule out other conditions such as UTI with the help of urine analysis, pregnancy with beta HCG. Even though the lady is postmenopausal, it's still possible. And STIs with gonorrhea, chlamydia, or trichomonas. And stage the patient with CT abdomen, pelvis as well as CT chest. In treatment, counsel patient about cancer diagnosis, consult OBGYN, surgery, hem-onc as well as radiotherapy, and pre-surgical labs such as CBC, BMP, LFTs, PTA, PTT, ECG, EKG, and blood type and screen should be done. And in advice, counsel reassure, and this is the diagnosis of vulvar carcinoma. Case number 15. 33 female who has amenorrhea, weight gain, increased hair growth, irregular periods, increased BMI, infertility, acne and hypertension. So all these signs and symptoms are pointing out towards the diagnosis of PCOS because of hyperandrogenism. And in examination, do a complete physical examination with specifically looking for in the skin increased hair growth, hyperpigmentation, acne as well as skin thickening. In the diagnosis, first of all, rule out pregnancy with beta HCG qualitative and fast forward to the results. Then do radiological tests such as transvaginal ultrasound to specifically diagnose polycystic ovaries, and get endocrine tests such as FSH, LH. LH will be increased, TSH, prolactin, testosterone, dihydroepiandrosterone, as well as total estrogen, cortisol, and androstenedione. Get metabolic tests done such as fasting glucose, lipid profile, as well as 24 hours glucose and androstenedione. And treatment is basically with combined oral contraceptive pills, which have both high levels of estrogen and progesterone to control to actually cure the irregular periods and the amenorrhea. And clomiphene citrate can be given if the patient intends to become pregnant, and metformin in case the patient has metabolic disease and the fasting blood glucose is increased. Advise weight loss, exercise program, weight loss diet, and consult endocrinology. Reschedule monthly and fast forward to the additional results, and the diagnosis is PCOS, polycystic ovarian syndrome. Case number 16. 50 female who has firm immobile unilateral breast mass. On examination, do a general skin, breast, and lymph nodes examination in order to look for some sort of pure orange in the skin, a general examination and a breast examination to look for the mobility or immobility and firmness or softness of the breast lump, and lymph nodes to look for lymphadenopathy. In diagnosis, if the patient has irregular menses, bilateral breast tenderness, and uterine enlargement, keep the diagnosis of pregnancy and getting a urine beta HCG done first of all. And after you are done ruling out pregnancy, then you can specifically get other radiological tests done such as mammography, ultrasound, and confirm with the histological diagnosis of breast biopsy, and stage this patient with CT chest and CT abdomen and pelvis once you are confirmed with breast cancer on breast biopsy. Then in the treatment, counsel patient regarding cancer diagnosis, consult general surgery or hem-onc radiology, and preoperatively get CBC, BMP, LFTs, blood type cross-match, EKG, as well as PTA, PTT done. In advice, counsel and reassure, and this is the diagnosis of breast cancer. Case number 17. Painless, firm, mobile breast mass in a 24-year-old female. So in examination, same, do general skin, breast, and lymph node examination. In the diagnosis, again, first of all, look for the enlarged uterus or bilateral breast tenderness, and then rule out a pregnancy with beta HCG. Then do a radiological ultrasound of the breast and histopathological diagnosis. You can do a mammo and then a breast biopsy, and schedule patient after all the results. And in the treatment, just reassure and counsel because the diagnosis is that of fibroadenoma. Case number 18, 24 female who has dysuria urgency frequency and has multiple partners. So on examination, since the patient might be having some vaginal discharge and erythema, get genitalia examination done along with general examination, abdominal examination for some tender enlarged uterus, again to rule out pregnancy, along with cystitis for tender bladder, and get a breast examination done to look for tenderness in order to look for signs and symptoms of pregnancy, because sometimes pregnancy also presents with dysuria urgency frequency. Now on the diagnosis, first of all, beta HCG fast forward results negative, urine analysis fast forward results rule out UTI, and with beta HCG rule out pregnancy, and get urine gram stain as well as urine culture sensitivity done since you are suspecting UTI as well. And if the beta HCG is positive, there are some other things that can be done, and this is what you have to remember for all the cases, that if whenever beta HCG is positive, you have to do a sort of like pregnancy, after the pregnancy confirmation, some sort of like the pregnancy tests done, and that would include a the general test of CBC, blood type and screening, antibody titers such as rubella and zoster, as well as infectious screening, which includes Hep B, HIV, RPR, chlamydia, and gonorrhea screen, right? So these are three general antibody titers as well as infectious screen if the beta HCG comes positive. Then if the patient actually has like urine analysis, and the urine analysis show like urine analysis abnormal and it shows pyuria, then you can go ahead and see if the patient is pregnant or not. So specifically, if the patient is not pregnant, then you can give like trimethoprim sulfamethoxazole, and then if like the patient is pregnant, then you will not use ciprofloxacin or trimethoprim sulfamethoxazole, but nitrofurantoin is a safe option in that situation. And if beta HCG is positive, again prenatal counseling and vitamins, folic acid. If gonorrhea is positive, get ceftriaxone. If chlamydia is positive, then you are going to treat for with azithromycin and doxycycline. And specifically, if you have done a chlamydia and gonorrhea DNA test, then you are sure that if only the gonorrhea is present, administer ceftriaxone. If only chlamydia is present, administer azithromycin or doxycycline, and doxycycline specifically if non-pregnant. If pregnant, azithromycin, and if pregnant, she can get ceftriaxone for gonorrhea. And if RPR is positive, then confirm with fluorescent treponema pallidum antigen and treponema pallidum antibodies FTA, and then administer penicillin. So the differential diagnosis for this case is UTI, pregnancy, as well as STI. Case number 19, 26 female who has dysuria plus vaginal discharge. On examination, do a genital examination looking for vaginal discharge, erythema, excoriations, and some yellow-green frothy discharge on abdomen. Again, look for tenderness, which might be pregnancy or might be some sort of cystitis with suprapubic suprapubic or bladder tenderness. And in breast, look for tenderness for signs of pregnancy, and lymph nodes can be enlarged in case this patient has HIV and multiple sexual partners. So in the diagnosis, again, first of all, rule out pregnancy with beta HCG, then rule out UTI with urine analysis, and get a routine pap smear done as well. Then specifically since you are suspecting some sort of vaginal infection with discharge, get a vaginal pH done, a vaginal QH done, vaginal wet mount done, and fast forward to the results. So it's possible that it shows vaginal pH of 5.5 with mobile trichomonads, and then you know the diagnosis of trichomoniasis, and get the STI screen done, especially if the patient has multiple sexual partners, with rapid HIV, Hep B, chlamydia, gonorrhea, DNA testing done, and possibly like RPR done for syphilis as well. And the treatment is metronidazole that you're going to continue for 7 days, but there is some important counseling and advice that to be done, in which you're going to advise the patient regarding medication compliance for 7 days. The partner also needs treatment until the time the patient is completely treated. No sex and no alcohol, because alcohol can cause disulfiram like reaction with metronidazole. Counsel, reassure regarding the side effects of medication, safe sex, and birth control. Continue the medication after 7 days, and the diagnosis is trichomoniasis. Case number 20. 24 female who has vaginal discharge that is thick white curd light, has pain during sex, and recently took clindamycin for dental infection, and she is in a monogamous relationship. So in the examination genitalia, look for edema, beefy mucosa, and thick white discharge of candidiasis. Along with, you can get to breast, lymph nodes, or a complete examination done. And the diagnosis in the general, again, as always, rule out beta HCG, pregnancy, urine analysis for UTI, and pap smear, along with specific examination of these three: vaginal pH, KOH, and wet mount, and do an infectious screen in case the patient has multiple sexual partners. Then go for the HIV, chlamydia, gonorrhea, as well as the RPR route and Hep B route, right? But otherwise, just like if the patient is monogamous, just stick with vaginal pH, which can be 4, KOH, which is hyphae and bud, since this patient was also taking clindamycin for dental infection and has thick white discharge, and you are suspecting candidiasis, and the wet mount shows hyphae. So the treatment is miconazole or clotrimazole for 7 days, and advise the patient regarding medication compliance, the side effects of the medication, and no sex up until treatment, and no tight-fitting garments, and discontinue the medication after 7 days, and the diagnosis is vulvovaginal candidiasis. Case number 21, 30 female who has found swelling vaginal discharge with itching along with multiple partners. So an examination, do a genital examination in which you can find thin gray malodorous frothy discharge, and you can also do a complete examination. In the diagnosis, get a general test done with beta HCG, pap smear, along with urine analysis. For STIs, you can consider getting a gonorrhea DNA test, chlamydia DNA test, along with HIV rapid test, especially since the patient has multiple sexual partners. And specifically, as we've already discussed, that the vaginal pH, KOH, and wet mouth should be done, and as well as the gram stain, specifically in this case, since it is gray malodorous frothy discharge, and you are suspecting bacterial vaginosis. So the pH can be greater than 4.5, KOH shows no hyphae, wet mount shows no trichomonads, but the gram stain shows small gram variable rods. Some are gram positive, some are gram negative. Treat with metronidazole for 7 days. Stop the treatment after 7 days. Advise no sex, no alcohol, side effects of the medication, and also advise safe sex, birth control, and reassure and counsel the patient. And the diagnosis is bacterial vaginosis. Case number 22, 60 female who has vaginal bleeding, has a history of tamoxifen or estrogen use, is obese, nulliparous, has had a liminarch, late menopause, and so all these conditions like this use of tamoxifen or estrogen are all conditions in which the patient has had increased estrogen exposure during the lifetime, and because of this, it's possible that she has some sort of endometrial proliferative disease or endometrial hyperplasia or carcinoma. So you have to examine the genitalia, general examination, skin, abdominal, genitalia, rectal, plus minus complete examination. And in the diagnosis, get the general CBC, pap smear, and if you are suspecting some sort of pregnancy, then beta HCG as well. And specifically get an ultrasound of the abdomen done in order to look for endometrial thickness, as well as endometrial biopsy to rule out a carcinoma. And if it's a carcinoma, endometrial carcinoma, get treatment done with surgery such as hysterectomy, pre-op LFTs, RFTs, stage it with CA125, chest CT, abdomen pelvis CT, and advise the patient regarding cancer diagnosis, reassure, consult OBGYN, radiation, and hem-onc because of the cancer treatment. Case number 23, 35 female who bleeds after intercourse and has been a smoker, has had early age first sex and lacks barrier contraception and has multiple sexual partners. So again, in this particular situation, these are all the risk factors for some sort of HPV infection, since all these conditions are predisposing her to unprotected as well as dangerous sex, so that predisposes to HPV infection. An examination, genitalia plus minus complete examination. On diagnosis, do a general examination, general tests, as always, rule out pregnancy with beta HCG, urine analysis for UTI, pap smear, as well as HPV DNA, specifically in this case when you are suspecting cervical cancer. For STI, screen since the patient has multiple partners, HIV, Hep B, maybe RPR, as well as gonorrhea and chlamydia. And specifically get colposcopy, cervical biopsy, and endocervical curettage done, since you have to make a histopathological diagnosis. Then for the treatment, stage with CT chest, CT abdomen pelvis, do a pre-op BMP LFT, CP, ECG, PT, APT, and blood type cross-match done, and surgery with LEAP procedure or hysterectomy. Advise the patient regarding cancer diagnosis, counsel, reassure, consult OBGYN, radiation, and well as heme-onc. And the diagnosis is cervical carcinoma. For our next case, number 24, there's a 16 female who has increased bleeding in periods and has a regular cycle, but she also has a history of nosebleed, bleeding after dental procedure, family history of increased bleeding. On examination, do a complete physical examination, specifically looking for signs and symptoms of like some sort of petechiae, purpura, bruises, and in diagnosis, do a general diagnostic test with CBC, PTA, PTT, beta HCG, as well as orthostatic vitals. And the PTT will possibly be increased if it is von Willebrand's disease. Fast forward to the result and specifically get factor 8 in the plasma done, which will be decreased, von Willebrand factor antigen, which will be decreased, riscoting factor, platelet aggregation, which will be abnormal. Then, if the patient has iron deficiency because of the excessive bleeding, then get the tests of iron ferritin and TIBC done, and in the endocrine, get a TSH done in order to rule out hypothyroidism, which can be a cause of excessive menstrual bleed. Then for the treatment, COCPs, and if she wants to be pregnant, then GDAVP and tranexamic acid or aminocaproic acid. Advise, counsel, reassure regarding the side effects of the medication, that is COCPs, no NSAIDs or aspirin, since they will promote more bleeding, as well as to compensate for the iron deficiency anemia, ferrous sulfate, and a diet high in iron, and the diagnosis is von Willebrand's disease. Case number 25. 15 female who has irregular periods, excessive bleed in period, plus she has excessive bleed between the periods, and the periods are lasting several days. So this is telling you the etiology, that it's specifically not some sort of dysmenorrhea but some sort of dysfunctional uterine bleed, and she has recently had her menarche at like 14 years of age, and now like her menstrual cycle is not going good, even like she has bleed between, she has irregular bleed and lasts several days, right? So the menstrual cycle is not going like really like on a particular schedule or regular. So in examination, gets general skin, lymph nodes, abdomen, chest, heart, rectal, genitalia, plus minus complete examination. Diagnosis you already know. Get a beta HCG as always, and CBC to look for signs of iron deficiency, decreased hemoglobin, PTA, TT in order to rule out some sort of clotting disorder, rule out then after fast forwarding the results, and these are all negative, then rule out PCOS with endometrial cervical lesion, endometrial cervical lesion with the transvaginal ultrasound, rule out hypothyroidism with TSH, and do an iron workup for iron deficiency anemia with iron, ferritin, and TIBC levels. Then in the treatment, give her estrogen and naproxen, ferrous sulfate, and a diet high in iron. Estrogen for the regulation of the periods, and ferrous sulfate and diet high in iron for iron deficiency anemia. In advice, counsel, reassure, counsel regarding the side effects of the medication, and the diagnosis is dysfunctional uterine bleeding. Case number 26. 44 female who has fever, chills, night sweats, or one day, and has AML on chemotherapy or is immunodeficient. So you already know whenever you are having fever, do a pulse oximetry done, and if oxygen saturation is low, administer oxygen. Do a complete physical examination, and in the diagnosis, specifically do general tests with CBC, LFT, BMP, and lactate. Fast forward the results specifically for the CBC in order to look for decrease in the absolute neutrophil count, and then rule out the source of infection with chemical tests such as blood culture, urine culture, stool culture, as well as urine analysis, and radiological tests such as chest x-ray, and admit the patient to the inpatient unit since this patient might be having neutropenic fever. Treat with cefepime, which is a cephalosporin, which has anti-pseudomonal coverage as well. Along with, you might get CT abdomen or chest, which you are suspecting some sort of complicated infection. Do reverse isolation, advise, counsel, reassure, consult infectious diseases, and monitor CBC as well as vital signs daily. And the diagnosis is neutropenic fever. Next, case number 27. You have 70 female with palpitations, fatigue, exercise intolerance, syncope, and dizziness. Do a complete physical examination in which, because of the palpitations, you might find an irregular pulse and suspect atrial fibrillation. And then for the diagnosis, do a specific test of ECG and fast forward to the results to find the irregular rhythm. Then do a general CBC, BMP, LFT, PT, APTT test done. And radiologically, since you have to like anticoagulate the patient, therefore you must get PT, APTT done, radiologically get echo and chest x-ray done, and for endocrine TSH, free T4, and cardio BNP as well as TROPT done. And in the treatment, if the patient is like stable, then he or she can be treated in OPD with rate control with beta blocker or calcium channel blocker such as atenolol or verapamil, and anticoagulation with warfarin, and if it is contraindicated, aspirin or clopidogrel. And if the patient is unstable, first admit to the ER, then do a transesophageal echo to rule out thrombus and start anticoagulation and cardiovert the patient. In advice, counsel reassure along with doing a cardiology consult, and the diagnosis is atrial fibrillation. Case number 28. 40 female who has decreased urine output after surgery has been on gentamicin. In examination, do a complete physical examination looking for increased skin turgor and peripheral edema. In the diagnosis, do CBC, BMP, fast forward to the results, look for increased creatinine and abnormal electrolytes. Specifically, do lots of urine tests such as urine analysis, urine sodium which will be increased, urine osmolality which will be decreased, and it is less than 400 in intrarenal as well as postrenal causes, which is whereas it is greater than 500 in prerenal and urine creatinine. So you are specifically, because of gentamicin and decreased urine output, suspecting an intrarenal cause with acute tubular necrosis. To creatinine clearance, phosphorus and magnesium. In the treatment, stop the gentamicin, start furosemide, and monitor the urine output, and monitor daily basic metabolic profile with urea and creatinine, urine analysis, urine output, urine osmolality. And in the pre-renal cause, treat with IV volume expansion and IV fluids, whereas the post-renal cause, treat the obstruction. In advice, counsel reassure, consult nephrology, and the diagnosis is acute renal failure due to acute tubular necrosis. Case number 29. 60 male who has 2 hours left-sided weakness that has resolved and or has had monoocular blindness, numbness, weakness, loss of consciousness that has resolved. Examination, do a complete examination specifically looking for carotid bruit, irregular pulse, and residual focal neurological deficit. Do a specific head CT scan done without contrast, fast forward to the result to rule out intracranial bleed or some sort of like a stroke, thrombotic embolic stroke and ischemic stroke. And in general, do CBC, BMP, PT, APTT. Specifically for cardiology, do ECG and drop, carotid Doppler, and metabolic fasting glucose and lipid profile. Admit in the patient in inpatient unit since there's increased risk of stroke within 48 hours of the TIA, do neurological tests every 2 hours, administer aspirin, dipyridamole, as well as do carotid angiogram. And if there are some sort of hypertension issues, then ACE inhibitors, hyperlipidemia, then statins, and increased blood glucose and metformin. In advice, counsel reassure if he has greater than 50% stenosis on angiogram, get carotid endarterectomy done, consult vascular surgery and urology, and the diagnosis is TIA. Case number 30. 35 female who has weight loss despite increased appetite for 3 months, has anxiety, irritability, mood swings, diarrhea, menstrual irregularities, and heat intolerance. On examination, do general examination looking for a thin, fidgety female, head, eye, ear, nose, throat, showing lid retraction, increased thyroid size, skin which is warm, moist, sweaty with hair loss. On heart, look for irregular pulse, and in neuro, look for increased reflexes. In diagnosis, do a prelim examination, a prelim test ruling out pregnancy with beta HCG, TSH and free T4, fast forward to the results, looking for increased TSH and decreased levels of free T4, decreased level TSH and increased levels of free T4, suspecting hyperthyroidism, and in general do CBC, LFTs, BMP, establish the cause then with radioactive iodine, thyroid autoantibodies for Graves' disease, thyroid ultrasound, and radioactive iodine uptake for toxic adenoma or multinodular goiter. Treat with propranolol for adrenergic symptoms, methimazole is preferred. Otherwise, if the patient is pregnant, use PTU, radioactive iodine if the patient has toxic adenoma or multinodular goiter and is non-pregnant. In advice, counsel reassure, consult endocrinology, schedule after 1 month, and do T4 TSH 1 to 2 months until the patient is euthyroid and the diagnosis is hyperthyroidism.